Good afternoon, everyone. Good afternoon, everyone. Ladies and gentlemen, distinguished guests, welcome to our Devex at WHA 77 ecosystem event titled Maternity Matters, Unlocking Private Sector Fiscal Capital for Health System Response. Now, this is produced in partnership with MSD for Mothers and the World Health Organization's Country Connector on Private Sector in Health. My name's Richard Jones. I'm editorial director at Devex, and I'm delighted to see such a full room and a diverse group gathered today here in Geneva and following along, of course, online around the world. Welcome to everyone. So today we're going to explore how strategic engagement with the private sector can really augment health system capacity and drive equitable access to quality maternal health care. Our discussions are going to focus on the crucial role of the private sector in addressing public health challenges, and specifically how we can leverage resources and expertise to close that significant health financing gap that affects reproductive, maternal, newborn, child, and adolescent health services. So to set the stage for our discussions, I'd like to invite to the stage Temitayo Erogbogbo, Director of Multilateral Organizations Engagement at MSD, and Advocacy Lead at MSD for Mothers, to share his insights. Tayo, can you join me on the stage, please? A big welcome, warm welcome. And perhaps you could just help us set the scene in terms of the current landscape and some of the opportunities for private sector engagement in really driving forward on maternal health.
Sure, and also building on what Richard has said, welcome to everybody joining us both online and also in the room. It's great to see a packed audience here. And actually, as I was coming in, I did have a prepared speech, so just in case anyone thinks I wasn't prepared. But over the last 48 hours, and also just broadly in terms of my role, I have a lot of conversations around this issue around the gaps within the health system, and what we need to do in terms of actually saving our mothers' lives and enable them to not only survive but thrive. And I was involved particularly in the session yesterday with AMREF. And then I saw Dr. Naveen Rao, who actually helped set up the MSD for Mothers initiative. And I was thinking, actually, building on all those conversations, what really we need to actually focus on is the basics. And the basics is simply this. If we actually think about what it takes to save our mothers' lives, the questions and the discussions that we're going to have today shouldn't really be happening. It shouldn't be happening because we put all hands on deck and we try to sort of think about those gaps in terms of what are the pragmatic things we need to do to ensure that they stay alive. And this is not theory. We all know what happened when the COVID pandemic happened. There wasn't a question whether you're private sector, whether you're from the civil society, or from. We basically all wanted to stay alive. And it's exactly the same situation. If we can think about it in terms of how many women are actually dying every single day, that's the equivalent of with 2 jumbo jets crashing every single day. And we know what it takes to actually save them. So the discussion of whether private sector should be at the table or not should really be theoretical in this day and age. And the reason why I actually pointed specific to Naveen is, and he'll probably remember this, that during General Assembly, in one moment of my, I guess, moment of despair, I wrote to him this long message saying, Naveen, what are we doing? I started this engagement in the public health sector with him something like 15 years ago when I was working in Nigeria. I came from Abbott. And literally, I looked at some of the talking points I gave 15 years ago related to this very same issue. And they were pretty much the same thing. And we're still having the same conversations. The bottom line is this. How do we save our mothers' lives? What does it take to actually get all our hands on deck to do this? We know that the private sector plays a significant role in settings such as Nigeria, where I come from. We provide 40 to 70% of delivery of care. They're helping to ensure that commodities can get from one point to the other. They're helping to train healthcare workers. They're involved in terms of development of commodities that are required for things like postpartum hemorrhage, which we know is the the biggest cause of clinical cause of death. But yet, when it comes to conversations and strategic thinking about how we respond, it's like, no, well, we don't know. We might not necessarily have a space for you at the table to discuss this. Why? The focus should be on the mother. The focus is on how do we make sure that she stays alive and she thrives. So the conversation today is going to be very much around that. Thankfully, we have ministers of health from both Nigeria, Kenya, and Sierra Leone here, as well as some of our partners that will work with us in a number of our focal countries, to be able to actually put some tangible insights into some of these conversations around, what it does actually take to ensure that our mothers do stay alive, and the role the private sector has to play in supporting this. So welcome again. I look forward to the conversation. On behalf of MSD for Mothers and MSD, we thank you for engagement, and also from the way in which we work collaboratively across sectors. So we look forward to working with many of you on this goal. Thank you.
I think both Richard and Tayo really set the stage for an important conversation that we should be having. And I just want to highlight a few things before I jump in with our ministers here. One of the things that Richard actually mentioned is that the World Health Organization estimates that 800 women around the world die from preventable causes of related to pregnancy and childbirth, and this is every day. And 95% of these deaths are in low and middle income countries. In addition to that, there's a 33 billion annual financing gap affecting reproductive, maternal, newborn, child and adolescent health. So I think when Tayo says this is a no-brainer, it's really like just apparent. Like, we need all hands on deck, as he mentioned. So to kick off the conversation, I'm just going to turn to the ministers that we have here and the government representatives that we have here, and just ask. Minister Dembe, I'm going to start with you. I want you to take us a little bit through how Sierra Leone is engaging the private sector and what successes your government has had so far. You can just speak, it'll start on its own.
Speak to the mic, yeah. Well, thank you very, very much. Again, I'm honored to be here today. Sierra Leone is going through some very interesting phase and really transformational phase in maternal and child health. A couple of years ago, Sierra Leone had the highest maternal mortality rate in the world. It was over 1,300 per 100,000. Pretty scary. The closest to Sierra Leone was about 900 and some per 100,000. So it was very dramatic. But with a concerted effort, we've been able to turn the tide around. It dropped from 1,300 to 717. From 717 to the last measure was 443. And I believe at the next results, we'll be pleasantly surprised at how low it's come. So we have some dramatic gains, and that's because we have a focused attention to maternal health. I would like to expound on that, some of the success factors, but maybe it's just as an opening shot to let you know that we're changing the narrative for Sierra Leone. And I think 443 per 100,000 is still way too high. We have a two-step approach. How do we get to less than 300 by 2025 and focus on bending the curve dramatically to get to below 70 per 100,000 by 2030? We have a game plan for that.
Thank you so much. Thank you so much, Minister. Those are impressive numbers, and I will come back to you just to dig a little bit deeper on what you're doing with the private sector and how they're helping you achieve these impressive numbers. But I want to turn to you, Dr. Aina. One thing that I know is that Nigeria has also, the private sector has been playing a very vital role in Nigeria and within the healthcare system. So can you take us through how you're engaging them and how your government is using an integrated private sector capacity to enhance equitable access?
Thank you very much. Just a couple of things before I get to your question. I think, in case you have not noticed, I'm not quite Minister Patti, but I assure you, I have his mandate to speak, on his behalf. Yes, so that's the first thing. I think the second thing is that, just recently, for us in Nigeria, WHO still estimated our maternal mortality rate to be above 1,000 per 100,000. If you layer that on our large population of 230 million-ish, I hate to say that we unfortunately contribute a disproportionate number to that number of deaths per year. So necessarily addressing maternal mortality is a national priority and a national emergency for us. As a matter of fact, the federal government, most of you may be aware that we have a government that is just about a year in office now, and the health sector is led by Minister Mohammed Patti, who's around. I mean, you've probably seen him in some sessions, but he's double booked at this time, so I'm standing in for him. The government signed a compact across the tiers of government that underlines or really legitimizes the Nigeria Health Sector Renewal Investment Program, which brings together the federal government, the state governments, development partners, and the private sector to really focus around a few core priorities. And number one on that, the president is very clear, is crashing maternal mortality. So that's really, really, one of the core things we're doing. And the health sector really articulated a blueprint, strategic blueprint that is anchored on 4 pillars. Getting to your question, the first pillar is really the overall goal is to save lives, to reduce pain, financial and physical pain, and to do that in an equitable way for all Nigerians. And that's anchored on 4 pillars. One of them is governance, which is really around the data and transparency and accountability of the health sector and really building stronger institutions. And then, am I running out of time?
No.
Okay.
I was asking for something else.
Okay, I was going to say no. All right. So the first pillar is around governance, and then the second pillar really is about improving population outcomes. Again, maternal outcomes is really a big part of that. Really using the primary health care system, again, enabled by the basic healthcare provision funds. There's a third pillar, which is really unlocking the value chain in health, and that's anchored squarely on the private sector, which is how do you build sustainability for our basic commodity supply chains. We're doing a lot in domestic manufacturing, food procurement and things to lower costs, but also just create a self-sustaining supply chain for that. And there is a fourth pillar around the health security agenda for the country. Of course, there are certain enablers. There's the data and digitization. There's a big drive to digitize the health sector from top to bottom. And a couple of other things. So there are a number of ways that the private sector really comes in here. I think I'll probably start with the service delivery component of things. Now, for maternal care, for example, we did some estimate recently that says we would need incremental funding of $30 to $60 million. Just to address the 10 worst affected states. Again, we've got 36 states and a federal capital territory, so 37 subnational units that are very different in terms of their access to services, in terms of their health worker density, facility density, but also outcomes. So what we did is you can't do everything everywhere. If you're going to prioritize these, 10 states account for half of the maternal deaths out of the 37. So those necessarily are the priorities. And we would need up to $60 million to do that. Now, the government is increasing funding, but that's not going to be enough. So we're really looking to the private sector in a number of ways. One is just private sector financing, some sort of direct investments in the health sector for service delivery. Some of if it is through PPPs, there's Dr. Ben here who's piloted things in one of the states where you have build, operate, transfer models for primary health centers, for example, there are equipment PPPs where basically you provide and recoup your costs over time. We have service providers, energy as a service, for example. So sustainable energy for health facilities, and the facilities subscribe. Fortunately, now we have the direct facility financing through the basic healthcare provision funds that guarantees them operational costs, that allows the facilities to subscribe to services that they need. There are a few other models, but I want to also focus on the value chain bit. A lot of the engagement of the private sector has really been around jumpstarting domestic manufacturing for health commodities. We are right now in advanced stage conversations with 3 global manufacturers of diagnostic kits, whether it's HIV, TB, malaria, things that we buy. We're a large consuming nation anyway. So things that we buy in bulk, we're really trying to accelerate the ability to locally produce them. We're having conversations around vaccine manufacturing. Those are, somewhat behind, but lots of actual conversations that are making progress. And there are a few blended financing conversations where you have private sector mixing with development financing to actually provide capital or investments, for some of the work that we're doing. Looks like I need to pause.
Yeah, Dr. I want to get back to that, but what I want to do is just expand our panel a little bit, and we're just going to ask Richard to make another introduction.
Yes, well, breaking news, we have been joined by Dr. Patrick Amott, who is Director General for Health from the Ministry of Health in Kenya. Dr. Amott, would you like to join Rumbi and our colleagues on the stage? Thank you.
Thank you so much, Dr. Amott. So, Dr. Mort, you've had panelists talking about what's happening in Sierra Leone, what's happening in Nigeria. And I know that Kenya has been doing a lot of work to improve maternal health. I just wanted to ask you, how are you engaging the private sector?
Thank you for that.
You just talk, it'll start.
Okay, thank you for that question. Kenya has made significant progress in reproductive, maternal, child, adolescent health. Looking at our Kenya Demographic Health Survey statistics for 2022, which were released last year, for example, skilled birth attendance stands at 89%. Nearly 9 out of 10 women deliver in a health facility under a skilled provider. If you look at antenatal attendance, again, that first antenatal ANC attendance is at 96, fourth ANC at about 66, 67. And if you also look at newborn, infant, and child mortality, again, we are on track to be able to achieve our 2030 goals. The only challenge we have is about neonatal mortality rate, which still is quite significantly high, and also maternal mortality rate is still high. We have tried to engage the private sector through various facets. One is health service delivery in Kenya is basically structured in 2 facets. The public health facilities deliver 50% of the health service delivery, and the other 50% is delivered by private and faith-based organizations. So in terms of service delivery, private sector is critical. Going further, as we journey towards achievement of universal health coverage, again, we have structured our health service delivery to be able to focus more on primary health care, which is integrated, comprehensive, and promotes inclusivity and equity. That we have established what we call the primary care networks, under which we operate under hub and spoke model. And this is not discriminative. The hub can be a private facility if that is the biggest facility in that region, and therefore then the spokes link to that hub in terms of service delivery. My colleague has talked about local manufacturing. Again, we are big in local manufacturing in the commercial region in Eastern Africa. And we are promoting local manufacturing, and not only promoting local manufacturing, but changing our laws to be able to ensure that the private sector can be able to thrive and they can be able to make investments. For example, we ring fence procurement of locally produced goods for local manufacturers, irrespective of the cost, because the cost could significantly be higher. But remember that the taxes are paid remain here. The people who are employed are Kenyans, and therefore they stand to benefit. So going forward, we want to promote local manufacturing. And one of the biggest local manufacturers of, for example, syringes for immunization, Revital, is based in Kenya. We are manufacturing CPAP machines through partnership with the private sector. We are now going big into liquid oxygen because of the lessons that we learned during COVID-19 pandemic. So we are ring fencing the space for local manufacturers to be able to thrive, but also making it possible through legislation. And the other thing is that in terms of the laws, the regulations, the policies in place, private sector plays a critical role. If you look at health workforce development, we have private institutions training our nurses, training our doctors up to the level of even specialists, like the Aga Khan University in Nairobi is training up to specialist level for medical doctors. So capacity building, again, the private sector continues to play a big role, especially going forward now with the tight fiscal space. Then you expect the private sector to be able to play a bigger role going forward.
Thank you so much. I want to dig into some of the challenges that you have experienced when engaging in the private sector. But what I'm going to do before we jump into that is I'm going to expand our panel a little bit more. As we mentioned, this is an all hands on deck approach. So I'm going to call a few key partners who are also involved in this fight. I want to call on stage Dr. Omobosola Asuni, who is the head of public health and program director for the 4-Mom project at Helium Health, as well as Dr. Messi Mwangagi, who is the Director of Health System Strengthening at AMREF, and Dr. Shanjana Bhattacharya, who is the Deputy Director for Women's Health and Primary Healthcare at the Bill and Melinda Gates Foundation. Thank you all for joining me on stage. Now, before we jump into the conversation with you, I just want, as quickly as possible, from the government perspective, can we highlight some of the challenges before we start talking to other partners? Minister Dembe, what are some of the challenges that you encounter when you're engaging with the private sector?
Thank you very much. I think for me, initially, I was just trying to lay the foundation of what was going on in Sierra Leone. But there are certain things that government does very well, and there are certain things that the government doesn't do well. And if we really want to make the kind of delta that we expect in maternal health, you have to have a combination and look for complementarity. For me in Sierra Leone, the bottom line is it's a small country. So from a manufacturing standpoint, it may not be worth one's while to start a factory in Sierra Leone, but with the West African Monetary Union that's going in, you have a strong base in Sierra Leone to supply the rest of West Africa. So from that standpoint, there's a really great opportunity in a very nascent space to be able to do something. I think for us, the biggest challenge is most of what we're doing has been more from the public sector, very little private sector engagement. But I think we're beginning to plateau off. And so the need for active engagement of the private sector is critically important. For me, one of the first things is Sierra Leone has 8 million people. We have about 300,000 pregnancies a year. It is important that if we want to get to the numbers that we're looking at, every pregnancy counts. And what that means is every pregnancy has to be exposed or familiar with the health system. And the health system should equally be active in engaging every pregnancy. So digitization is not a luxury. It's a requirement now. So one of the tools that we're looking at in Sierra Leone is to look at a new local developed press track that allows you to have a pregnancy be registered with geolocation. And what that means is that for every encounter that you have with the health sector, you're supposed to have 4 encounters. We're asking it to go up to 8 encounters. At every encounter, you have a solid workup, because the difficulties we have with pregnancies with maternal mortality is not a single event. So you have to be engaged with the pregnancy even before the pregnancy occurs, all through the pregnancy, at labor and delivery, and post-delivery. And all of this create opportunities for the private sector to engage. First, looking at the digital solution. And what we're also looking at is client-centered care. So we're not looking at malaria or TB or HIV. All of these are relevant to the person. So we want to be able to see how your malaria program impacts the pregnancy, how the TB impacts the pregnancy, how the nutrition impacts the pregnancy, how distance, how social factors impact the pregnancy. And for you to be able to conceptualize all of this, it's a multi-dimensional thought process that requires more than your ordinary Excel sheet. It is a great opportunity for innovators to help us look at this 360 around the pregnancy from the time they register till we land them. The other opportunity I see with the digital space is that right now we have it drilled down to a color code. So you can have a complete profile of the pregnancy with every visit, all of the data that's gathered around it. But if it's a normal pregnancy, it's shown as a green dot. If it's a pregnancy with comorbidities, it's a yellow dot. If we lose the pregnancy, it's a red dot. And so I could sit here and open my laptop or open my phone and have a scattergram of all of Sierra Leone and see all of where my pregnancies are. If there's a cluster of green pregnancies, I am happy. We try to keep it green. If there's a sprinkling of yellow, we want to see where the yellows are. How do we make them green? If we see a red, we're not going to wait till the end of the year to have an annual report. We want to know what happened so that we could fix it before you go to the next week or the next month. So I think for me, it's describing a scenario, and I want your business minds to light up and see where do you fit in this model for Sierra Leone on the one hand, but also as a model for the continent. Because for 8 million people, 6 miles, 6 hours end to end, it's less than a state in Nigeria. But if you could do it in Sierra Leone, you could do it everywhere else. So great opportunities all along the value chain. And I'm looking for you to give me ideas as to how we can make this work.
That's a very interesting challenge from Minister Dembe, and I'm sure we've got partners here who might be able to have answers for you. So do stick around after this to talk to the minister. But Dr. Ayina, if you will allow me, I have a tough challenge for you. Would you tell me in 3 sentences what are some of the challenges that you're experiencing when engaging with the private sector?
I think it's a number of things, largely. There's the policy environment that we met that wasn't necessarily always the most welcoming for private investors. And what the government has done is the president actually established a presidential initiative on value chain headed by a national coordinator. That's how much prioritization is given it, and quite a bit of policy imperatives have been driven through, quite a few executive mandates actually, including things around digitization, including things around allowing flexible pricing for locally manufactured goods and things like that. So that's one of them. The other, of course, is then the issue of access to finance. Sometimes this applies a lot more to the domestic private sector, rather than the global private sector. And again, there are quite a few things. There's collaborations that the health sector is having with the Bank of Industry, but also with a lot of our social investors and development partners, IFC and GoUp, putting together solutions to address many of this in a way that the government is involved and not really underwriting it, but providing some sort of guarantees around that. I think the third, frankly, is really around retention of the capabilities. So one of the very big differences between the private sector and the public sector is that the private sector is well suited to innovation. So the type of talent that the private sector needs to hold that space is a bit different from what we need in terms of technocrats, civil servants who are here for the long haul until we retire, basically. I happen to come from a private sector background, so a little different, but with the mobility of talent and some of the macroeconomic challenges, not just in Nigeria, but in other countries, what we're finding is the domestic private sector has also struggled to retain some of the cutting edge talent that they need. But there are, again, specific initiatives that are trying to solve that. That's more than 3 sentences. Those are 3 points.
No, that was really well. Same challenge for Kenya. Are you experiencing the same types of challenges?
Yeah, basically we experience the same type of challenges, but I can highlight a few. One of the challenges that we face in interaction with the private sector, of course, is suspicion. The moment they see people from the public sector, there's always that feeling that they're up to no good. And that is the reason why, in terms of development of our policies, our guidelines, we now embrace a whole multi-stakeholder kind of approach to be able to get everybody on board in terms of development of policies, guidelines, and strategies. Number 2 is visibility of the data from the private sector has always been a big challenge for us. In terms of our planning, we tend to use most of the data that comes through the Kenya Health Information System is actually from the public sector. And since our private sector delivers 50% of the services, that is a big chunk. We are only looking at half the cup. And that is why, in terms of our journey towards universal health coverage, then digitization becomes key. And what we are saying is that you don't have to. What we want to do is to develop a super highway into which you just need to hook up. You can have your own system, but so long as your data then is visible on our side, then we are good to go. Then the other challenge that we face with the private sector, and which sometimes is a genuine complaint from the private sector, is in terms of governance. In terms of the regulatory bodies in the health ecosystem, tomorrow is the regulatory body that deals with the doctors and the dentists visiting a facility in the afternoon. The Nursing Council of Kenya is there with a different team. The following day is a different team from the laboratory, and then that stifles the entire ecosystem. And that is why we have come up with an overall overarching body to be able to bring these actors together so that we have a kind of one unit going to do inspection. When you are going to maybe visit a facility, you have the board representing the doctors, the nurses, the laboratory, and the pharmacy and poisons board. That way then makes it easier for the private sector to operate. But we believe going forward that the private sector is going to play a bigger role as we move from the National Health Insurance Fund to Social Health Authority with the primary care networks. And in terms of the governance structure of the primary care networks, the private sector has a seat on that table in terms of the decision making, and therefore going forward, they'll be very critical in terms of service provision. The other challenge which cuts across both public and private, of course, is quality of care. Sometimes you find you go to a private facility where quality is really compromised because people want to expand their margins. And finally, I want to talk about accountability. If you look at claims from the Health Insurance Fund, ordinarily, you don't expect any queries from the public health facilities. Sometimes private sector tends to over-provide or tend to claim for services that have not provided. And we believe going forward with technology, using IT and artificial intelligence, then you can be able to flag those ones out.
Thank you so much. And I will come back to you guys for a few more thoughts, but I just want to jump to our other panelists. All our panelists here have been operating within mixed health systems. So I'll start with you, Dr. Sanjana. The Bill and Melinda Gates Foundation has been instrumental in advancing maternal and child health. I think we all can't deny that. How is the foundation leveraging mixed health system to support public health goals, and what successes have you seen so far?
I think sitting here and hearing the honorable ministers and senior government officials officials speak, it has been very encouraging in many ways to hear the different sort of work being done, but also the challenges, but also how we're trying to find solutions together. The foundation has, of course, committed to our work in women's health, in gender equality, and really trying to see how to make these systems work for women on the ground. But I want to bring one piece of thinking into this. I mean, as we're looking at maternal mortality and looking at how to change the trajectory for our mothers on the ground, it's also critical to look at that full arc of what we want to do. And I think that's where you see the links with the different systems in play. For example, if you're looking at even prenatal, so sexual reproductive health, family planning, which is also important in terms of the bigger impact we want to make on maternal mortality. And then you're looking at your antenatal, your actual time of delivery, and your postnatal. So that entire arc that is across women's health is so important that we're working together with the private sector. And we've been doing that in terms of making sure there's contraceptives available to the last mile for women. There's quality antenatal care available. So you need to look at that. I want to say that as one point. The second point is, as you're going through this arc, it's also important that you have an end-to-end view. So what we mean by that is really, if you're looking at the private sector and the public sector and the work that has already been spoken about, there's a critical role for R&D in that. So there's research and development, there's investments in research and development, but it's not just R&D for the sake of R&D. It's for R&D to meet the needs on the ground, the challenges that are being faced on the ground. And that's that important dialogue that needs to happen. So you don't just bring in people from different sectors at the very end. You bring them in right from the very beginning. So you're sitting across the table, around the table together, understanding the issues, understanding the data, trying to find the problems and solutions. And then you're working together from an end-to-end perspective of actually finding a solution, taking it through the policy aspects of what needs to be done, the guidelines, and then looking at the actual implementation, the delivery, and the impact. So that whole piece of work, if done together, and you're not bringing people in piecemeal, creates a sort of partnership that is much stronger in terms of going forward together. Let's say one example on the, we've been talking a lot in during these next few days around the postpartum hemorrhage and the number of women that we lose every year. Almost 270,000 women die each year, and we know this, and we know almost 70,000 are actually suffering from postpartum hemorrhage. They die, and on an average, on a bigger scale, 14 million women actually suffer from postpartum hemorrhage, and something needs to be done. Now, I know many of us in the room and others know about work that was done and research and evidence that shows that a bundle can actually be delivered, a PPH bundle, either emotive trial, that actually can make sure that you do not lose the mother. Now, delivery of that bundle requires a certain set of things within that bundle, which is commodities, which is making sure you have the right things at the right place at the right time. And here's again a concrete example in working with the private sector to make that happen, in working with the manufacturers and working to make sure your price reductions are there, your quality products are there to be able to get to that last point. And we're working very closely with the Nigerian government under the leadership here with Dr. Mui and Minister Pate to really make sure that we are able to bring local manufacturing calibrated drapes, for instance, as part of the PPH bundle and take that to scale. Now, there's a cost to it. And there's a high, obviously the cost is high. And so how do you decrease the cost to even less than $2 per woman, which is approximately $5 right now? And these are some of the concrete things that the private sector can work with.
Thank you so much for that breakdown. Dr. Suni, I'm going to jump to you, and I have a double question for you, unfortunately. Can you first take us through how the 4Mom project is working within mixed health systems? And then in addition to that, can you tell us how you're addressing unmet needs through your work?
All right, thank you. And it's also a privilege to be here speaking with all of you. Okay, so the 4Moms project is an MSD funded project. It's been implemented by 3 organizations: Helium Health, which is a digital tech organization; Solina is an African management healthcare consulting firm; and Afrida, who works with the informal sector. So within the 4Moms project, we have 4 interventions, and I'm happy that we covered most of this. And one is health financing. We provide health financing to, the mixed health system. So the private sector and also looking to also engage the public sector. We also do digitization of patients' records. So we deploy a hospital management information system to streamline the data management process and allow for visibility and improved operational efficiency. And then there's also capacity building. So the capacity building, it's looking at both the clinical and administrative staff. So we deploy, because we know adults learn differently. So using mixed methodology, like the in-class training, on-the-job mentoring, to ensure that they're able to provide care to the women. And finally, so all of this is the supply side. Finally is the demand side, where we go to the community. So the facilities that we engage are in, low, middle income areas where you have people that can't really afford healthcare as such. And so we map the communities around these facilities. We engage the community influencers, and through them, we're able to meet the women in this environment to understand what the barriers to healthcare are, and we're able to incorporate the voices, right, and give these facilities feedback so that they can tailor the healthcare to make it acceptable for these women. In terms of the challenges or the unmet needs, right? I'll start from the community. The first is access to information. There's a lot that goes on when you engage the women. There's a lot that goes on in their minds. You'll be surprised that you have your facility, you paint it up, you resource it. But when they see that facility, there's the perception that I can't afford it, and so they don't engage. So there's a lot of community awareness about the services provided, about the cost of care, because when they go to other informal sector, other places, when you look at the cumulative amount spent, is actually more than they would have spent within the formal sector. Another unmet need is, access to quality care. A lot of them, they demand quality care, but there are nuances to what they want. We operate in Lagos, Delta, and Kano, and these are very different, healthcare archetypes. For the women in Kano, when we speak to them, they want culturally sensitive healthcare. They want more women attending to them. For Lagos, they're saying, Lagos is more of a metropolitan city, so they're thinking we want more comprehensive care. We don't want to have to go outside the facility to do certain tests. We want more programs. They are more exposed and they want more. So it's really about tailoring this and ensuring that healthcare is, provided in a way that they can accept and meet their own needs. And regarding quality of care, within the facility, it's access to essential medicines for maternal health. It's also availability of staff with a high attrition rates and upskilling those. So within our package, because we do the health financing, ensuring that we're able to, fund or finance the providers to invest in equipment. So we give financing for working capital, there's asset financing, and also for those that believe that, they can have a facility expansion where there's a vulnerable population that need access to healthcare. And also, having that they're able to have enough money or capital to invest and provide quality care. So looking at that and also looking at the capacity building and the intention models, we're able to address all of these unmet needs.
Thank you so much. Dr. Mercy, I'm going to turn to you. I want you to first of all start off by breaking down how AMREF is working within mixed health systems. Then I want you to go into some of the barriers that you're experiencing when trying to integrate private sector efforts with public health initiatives.
Fantastic. Thank you, Rumbi, and thank you to Devex for hosting us today. I think private sector has an undeniable role when it comes to making contributions to reduce maternal mortality. And AMREF has had various partnerships with different elements of the private sector. I'd like to appreciate Dr. Amot for sharing with us that the private sector is not monolithic. It's not just the provider. There's so many other facets of the private sector. And interestingly, when we sat here today, I haven't heard people talk about the transport system. I haven't people talk about the water system, the food systems. That is part of the private sector, and they're so, so crucial. Now, AMREF has done a lot over the years when it comes to supporting maternal mortality interventions. One of the things that's hot off the table right now, and particularly in Kenya, is, and the Kenya team is here, they're working on what they're calling the big bets. The big bets when it comes to maternal mortality. I think Dr. Ndembi has shared with us the trend in Sierra Leone. Countries in sub-Saharan Africa have made a lot of impact in reducing maternal mortality, but something happened 7 years ago, a stagnation. Nothing has changed. And if we unpack the financing space of private sector, public sector funding, global maternal health funding, you'll also note that since 2017, and I saw a BMGF report on this, there's been a decline in financing for maternal health interventions. And so really now is the time to come together and work together around this space. How has AMREF done it? One, we are supporting what is known as looking at service delivery restructuring, and particularly for primary care health. AMREF has supported Kenya and various other countries with their primary healthcare service delivery models. In Kenya, we supported different counties in setting up primary care networks. And the idea is to be able to get care closer to the patients and to get efficiencies in the system. AMREF has also done a lot of work when it comes to capacity building and particularly in case management for our healthcare workers. We work in various countries, close to 8 countries in Africa. And in all those countries, we've put in place interventions on how do you ensure you manage postpartum hemorrhage correctly? How do you ensure you identify sepsis at the right time? How do you ensure you're able to take care of a newborn child at preterm and ensure they get the care that they need? We've done this over the years, and we've been able to make numerous investments that have led to different elements of setting up our Institute of Capacity Development, where you can actually access these courses, and we've been able to roll them out across different countries. Now, coming back to the big bets work, we've sat here, this is my 8th assembly, and I was just telling somebody down there in the coffee bar, I don't know if I'll do the 9th and 10th, because the story is becoming very familiar. We come in and we say the same things. And one of the things that's really exciting for us right now in AMREF is the work that the foundation is doing, particularly on making big bets on 5 key elements that perhaps if we scaled these in our health facilities, we might be able to make some gains. What are these elements and what do they address? They address the good old things that we all learned: postpartum hemorrhage, sepsis, obstructed labor, getting the mother, all the 3 delays in terms of getting a safe delivery. They attend to this, but then they answer questions on why have we been doing the same thing over and over again and failing? We've all talked about oxytocin. Perhaps do we find a molecule that's stable and that is easily accessible to our mothers? We've all talked about measuring PPH. Perhaps if we used a drip that provides a visual element to the loss of blood, then that will make us act as healthcare providers. We've all talked about ANC care and elements of iron deficiency. Perhaps we need to talk about iron infusions with our mothers early on, at least 1 infusion to save their lives. We've all talked about sepsis. How do we avail amoxicillin and gentamicin on time? We've all talked about our newborns dying. Do we have CPAP machines? And as I conclude my remarks, I sit as a chair of the board of the 2nd biggest maternity hospital in Africa. And every year we do 20,000 deliveries. This hospital is known as Pumwani Hospital. 2 days ago, the CEO sent me a message to alert me that we had a maternal mortality. And when we were doing the surveillance report, which I already have right now, this mother actually first accessed care in a private facility. She's been going to a private facility for her ANC care. Her HB was 4. And so by the time she landed into our hospital, within 10 minutes, she was collapsing while being attended to. I want us to understand that, a patient doesn't necessarily categorize healthcare into private and public. It is one system. And most of us, even those of us who are here in the room, you may end up in a private facility at some point, but chances are you walked through a public one and you intersected back and forth within the two centers. And so how do you ensure that these interventions are present? One of the things that we've done, supported by AMREF, is bringing together satellite private sector facilities that are around public facilities such as Pumwani Hospital, and bringing the managers together and supporting private confidential inquiries where you create a safe space to be able to have the discussion of why did you look at a mother who had a HB of 4 and let her walk around and go back home. So those are some of the things that AMREF is doing. Thank you.
And thank you so much, Dr. Mercy. At this point, I want to turn back to our government representatives. So you've all heard how the Bill and Melinda Gates Foundation, AMREF, and 4Mom are leveraging private sector capacity in their countries. And they've also spoken about some of the gaps and some of the barriers that they're facing. Are there any steps that your respective governments are taking to address these gaps? And maybe you guys want to make some news and commit to taking any further steps. I'll start with you, Minister Dembe.
I think for us, we have looked at processes and we looked at outcomes. Our primary focus is on health outcomes. And like I said before, every pregnancy matters. So for me, it's the 360 around that pregnancy, ensuring that you have proper ANC visits, ensuring that you have heat-stable cavitation available, ensuring that you could follow the pregnancy from the first encounter with the health sector all the way post-labor and delivery. I know that there's several components of this that the private sector would help us with, will do even more effectively. I don't want to go down the list, but there's a long list. I mean, for example, looking at pharmaceutical products by themselves, looking at the lab capabilities and lab capacities, looking at imaging and things like that. All of those are complementary to what the public sector could provide. We think the private sector could provide much, much more effectively. At the end of the day, what we're doing in Sierra Leone, we have 16 districts. We're decentralizing. The government's role is to create these standards and engage private sector, NGO, faith-based organizations to work in their different domains. What we have is a dashboard that I see what's going on. They see what's going on. The districts compare with other districts. The chiefdoms compare with other chiefdoms. The facilities compare with other facilities. There's added pressure to focus on health outcomes. I think there's a big role for private sector in helping us grow that process. But at the end of the day, what we want to see is at every encounter, did you do everything that you're supposed to do and follow this pregnancy all the way to labor and delivery and post-labor and delivery? By the way, for us in Sierra Leone, this is just a window of our approach to healthcare delivery because we're following life stages, all the way from pregnancy till the baby is born, till the baby is ready for school, till the baby goes to school, till it's an adolescent, an adult, and a senior citizen. All through these life stages, we're looking at what are the health interventions that we'll have to put in place to ensure appropriate health outcomes, focusing on patient-centered care, client-centered care. And for example, with pregnancies, what we're doing now is for every identified pregnancy, there is, with this new app, you could pick the health facility that you're much more comfortable with. And that health facility will have a healthcare worker that's dedicated to that pregnancy. That that person has a responsibility for the 20 pregnancies or so they are managing to ensure that they come to the ANC clinics, to ensure that their malaria tests are done, to ensure that they have bed nets available to them, to ensure that there's iron deficiencies detected early and addressed, to if there's malnutrition. I mean, all of these factors are built in, and we want to closely monitor and we judge success by health outcomes.
Thank you so much, Minister. And Dr. Ain, I'm going to turn to you. How are you addressing some of these barriers?
Thank you very much. I think similar to Sierra Leone, we're also laser focused on outcomes, and we're doing that through a number of things. One of the biggest gaps that we found is we just don't even have enough functional private facilities, period. So we've got about 34,000 facilities that are defined as primary health facilities. About 26 or so thousand of those are public sector, but we did an assessment of the top 8,000 plus over the last couple of months, and just barely 2,000 of them actually met the bar of basic maternal care services. So when you can say a pregnant woman can walk into this facility and safely be delivered of her baby, so that's really far from where we need to be. So our commitment as a government is that over the next 3 to 4 years, we're going to increase the number of functional primary health care facilities to 17,600. That means the infrastructure is of such decency that it's dignified enough. Secondly, the workforce. We're working with partners to increase productivity, production, to increase retention and incentives to keep them there, but also the equipment on the one hand, but also, so of course we do look to the private sector for injection of capital in different models, either through grants, through investments, and whatever different models. We're also looking at the quality of care. I think one of the areas where we're really looking to partner with the private sector is in really measuring the quality of what we're doing and being able to respond very quickly. So we'll go underlying that is a robust data systems. We also have a plan to identify every pregnant woman. In fact, whether for children that are missing immunization or women that are pregnant now, we're doing the name listing and identification in a way that is then being or will be digitized to be able to track, similar to what they're doing in Sierra Leone.
Okay. Thank you so much. It always builds so much confidence when you hear that your government is laser focused. So I'm going to turn to you, Dr. Amon. How are you addressing challenges, and are you also laser focused?
Similar to my two colleagues, are trying to address the challenges in basically a similar way, though the metrics may be a little bit different. We are also really focusing on primary healthcare services, strengthened primary healthcare services. We have a team of community health promoters, 107,000 throughout the entire country, paid a stipend by both the national and county governments, kitted with an electronic device. So going forward, we want to be able, and we have the geo coordinates of all our facilities, both public, private, and faith-based. And therefore, we think that if we can be able to leverage on these community health promoters, we can be able to track every pregnancy till the end. We have also done an assessment of all our health facilities in preparation for our scale-up of universal health coverage. And the gaps that we have identified includes gaps in equipment, health workforce, and infrastructure. Those are ripe areas for investment by the private sector. For example, one of the gaps that we really have is in terms of diagnostic capacity at our primary care levels. And we are saying that we can be able to work with the private sector, equipment placement, and then we can be able to work out a matrix of how the payment is done to the private sector over a period of time. Then the other thing that we really want to do is, of course, digitization, so that we can be able to have the visibility of what happens in the entire ecosystem, not only the public space. And therefore, the private sector has a role to be able to play, to invest in digital technologies in our the facilities so that that becomes visible. And number three is the fundamental change in the law regarding social health insurance, moving from National Health Insurance Fund to what we call the Social Health Authority, where your facility, you are accredited by the service you offer. Not like before, where would be able to give indicators like, oh, you have to have 2 acres of land to be able to qualify to be this level of service. You have to have this number of staff. So irrespective of the size of your facility, provided you are providing a service, then you are accredited by the Social Health Authority, and therefore you'll be able to get reimbursement from the Social Health Insurance Fund. We have also established 2 other funds, the Primary Healthcare Fund, which is funded principally by the Exchequer, and the Emergency Chronic and Critical Illness Fund. For example, in our previous dispensation, if a mother, under the previous insurance scheme, if a mother required dialysis, that scheme would not be able to support you. Now, because of that, the new change, then if you run out of your social health insurance scheme, then you automatically kick to the next level, which is the Emergency Critical Illness and Chronic Diseases Fund. Same thing used to happen. A mother comes with antepartum hemorrhage, bleeding. The private facilities were not willing to be able to accept if you are not able to put a deposit of maybe 50,000, 100,000 Kenya shillings, but now you are assured, and this is captured in law, that within the first 24 hours, whichever facility you go to, the government is going to meet that cost through the Social Health Authority.
Thank you so much. I know I've been really selfish with our panelists. I still have a couple of more questions, but I'm going to turn to the audience. I know some of you have got questions for our ministers and our partners as well. So if you do have a question, just raise your hand and we'll come to you. Yes, we've got one right in the front here. Please tell us your name and where you come from, and you can address the question to one of our panelists.
Thank you very much for the opportunity. My name is Mary Muya. I come from Nairobi, Kenya. I am a soroptimist, and I'm also a public health professional working in the civil society space in Kenya and in Africa. I want to appreciate the speakers and really the good work that is happening, and just have one question for our ministers. When it comes to private sector and also partnering with production and innovations and all that, I have heard them talk about the challenges of one country not being able to manufacture because of market and all that. However, I know as Africa, we have the Africa Medical Agency treaty that we all ascribed to as nations. And I don't know, I know my country already signed up to it. I'm not sure about Sierra Leone. I'm not sure about Nigeria. And then, because that is what would really make us cohesive as a continent, so that then we can produce. And if Sierra Leone is producing syringes, Kenya doesn't have to produce syringes. They can produce the vaccine. And, you know, the other country can produce something different. And then we will be able to do trade in Africa, and all the facilities will have equipment. So maybe that is what I could want to hear from Sierra Leone and Nigeria in their position for ratifying the AMA ratification in their.
Thank you so much. That's a really great question, because we've been following the ratification of this AMA treaty at Devex, and we're really curious to have more governments committing. But what I'm going to do is I'm going to take 2 more questions, then we'll turn to our speakers to answer. I know there's one right here. Am I correct? Was that a question? No, don't worry. I'm putting you on the spot. Do we have any more questions? There's one at the back.
Thank you very much, and I want to appreciate all the excellency in the room. But my question is about the 2001 Abuja Declaration, and this has to do with financing. So where are we, and where do we hope to get to? Finally, to my DG, Primary Health Care, thank you so much, sir. Since you came on board, you've been so active. But my concern is about midwives and the nurses, which I'm one of them, that are migrating. What are the plans? Because we know that when you engage the nurses and the midwife in the continuum of care, they will be able to save more lives. Thank you so much.
Thank you. We didn't get your name, hey?
My name is Lawan Ayedun Olubumi from Nigeria.
Thank you so much. And I will take, yeah, I know I'd pointed to you. I heard there was one right in the front somewhere. Oh, okay, Dr. Sheila. So we'll take one here and then we'll take Dr. Sheila and then we'll jump into some answers. Just here, second row. We'll start with her in the corner. Okay, Dr. Sheila.
Okay, thank you very much. My name is Sheila Tlo. I'm former Minister of Health of Botswana, and one who can pride herself with having had enough resources put into healthcare to ensure maternal health. Now, I wanted to find out from the ministers, thank you very much for your presentation, Minister and the representatives. How has the Abuja Declaration been implemented in your countries? Because when I was minister, I know it was only Botswana and Namibia, in the whole of Africa, that had put at least 15% of their budget to health. And it was therefore easy to be able to work with the private sector, knowing full well that we can stand on our own. So I'm trying to find out how is that, and does it bring any problems in terms of your capacity to be able to meet the private sector on equal terms? Thank you very much.
Thank you. And one more question.
Hello. Thank you very much for a very engaging event. My name is Dr. Esemoko. I'm a consultant gynecologist. I'm from Nigeria originally. I'm based in the UK. So my question is with regards to the concerns around accountability when it comes to private funding. I was curious from the perspective of somebody, I guess as a public servant, what kinds of things do you think are important from your perspective when engaging with the private sector that gives you the reassurance around accountability? But also on the flip side, of course, I know you're not representing private companies just now, but as somebody hoping to benefit from that source of funding, what kinds of things do you think are important to, I guess, showcase to your private partners with regards to accountability?
Thank you so much. Those are some strong questions. You guys could all have my job here. So I think these mainly at our government officials and talking about a few treaties, the Africa Medicines Agency Treaty. Are we ratifying that? How do we feel about it? When can we expect ratification from other countries? I know that there's indication that Kenya has already ratified that. And then in addition to that, the Abuja Declaration, which is really important because it talks about government commitment in financing. Where are we on that? And are we making this commitment for financing? And where do we stand when you talk about accountability? Dr. Aina, I'll start with you.
Okay. I said that because I can speak for 2 hours on these questions, but I'll try to not. I think on the treaty, I have to check where my country, that particular treaty, I have to check where my country is on it, just to be very sure. But I'm aware that there are quite a few other regional trade treaties that we're bought into, but that we're even driving actually to solve some of those exact same issues around how do we make a market around Africa, or in some cases, just even West Africa, rather than just Nigeria. And so we're coordinated in what we produce and what we export. I'll let the minister speak a little bit more. Somebody did ask about, I think the shorter one actually, let me go to that, is the Abuja Declaration. As of last year, Nigeria was far from meeting 15%. And we're not there now either, but I can tell you that for this year, the new government invested quite a bit more money in health sector. My agency literally had our capital budget tripled, just from year on year, and it's the same for all of the other health agencies. Now, that doesn't translate to the 15% that we want to get to, but I think it's a gradual process, and we have to also understand that our countries operate within a fiscal space, and there are many other priorities that feed into health as well. There's education, there's WASH, there's security, there are all of those other things as well. So as we are pushing and advocating, the other sectors are pushing and advocating. But there's another consideration there, which is that it's one thing, and I've seen this personally as well, it's one thing to commit the resources, it's another thing to spend it well. One of the bigger problems that we have in the public sector, at least if I speak for my country, that we've had is just inefficient spend as well. So both in terms of how you're allocating the spend to match your priorities, and you don't have access to basic services, but you're constructing eons of tertiary facilities, that no one's going to get to, that you don't even have doctors to staff, for example, just because those types of decisions, we're trying to move away from them to be more intelligent with whatever we have and get more health for the buck. Just like we're trying to raise more money for health. For the health worker migration, big issue. I think it's a two-coin thing, and that's something that I personally feel very passionate about. I think it's one thing to put it on the LMICs to solve, but basically, if you look at what is happening globally, is that we're producing health workers for the world. It's very difficult ultimately to say stop it. Nigeria or Kenya is unlikely to be able to compete with the UK or Canada in terms of salaries. Individuals will ultimately make individual decisions to improve their lives. So we need to be very realistic. There are many things that motivate people, and we're trying to solve some of them to the extent that we can. For midwives, for example, it's accommodation. So we're now incorporating residence facilities in each of our PHCs that we're constructing. It's things around incentives and lifestyle. We're structuring their work schedules to allow shifts that they can work in the rural area for some part of the month and go back to the cities where their families can have a decent livelihoods and they can get schools for their kids. We're being very creative. The government also just announced an increase in the minimum wage to try to solve some of that across board, but of course the health workers will also benefit from that. But I think, and also just from a production perspective, over the last several months, the minister has pushed and has actually achieved the actual doubling of production capacity of all of the training institutions, especially for doctors, for nurses, and for midwives. That said, a lot of what we're producing is going to continue to exit because the gaps in the rich countries continues to widen. The population is aging, we have the young population, and we have decent enough academic institutions that actually produce doctors and nurses that can take care of people in all of these countries. So that pull factor will continue to be there, even if the push factor is able to be attenuated, which will enough itself will take a while. So the question to the global community is, how are we thinking about that? If we're less resourced, we're investing in producing health workers, we're exporting them to the developed countries, what do we get in return? Should there be some thought? Should there be some thinking around, investments, maybe a global coalition to invest in production? We've got the population, we've got young, smart people, we've got academic institutions, we can create more. So we're happy to produce health workers for the world, but it actually costs money to do it. And when I went to med school in Nigeria, I paid maybe the equivalent of $30 now for tuition. And it's not that different even now when you go there. So when you think of, and someone's bearing that cost, it's the government that is typically bearing the cost. And then we graduate and then we go abroad. So how are we thinking about that? Thank you.
Thank you. That was that was something I'd actually never considered, really out of the box thinking, how can we think about a solution globally? Minister Dembe, we have a few more minutes. Please, I know I've asked you over 3 questions.
Yeah. So on a quick note on AMA, usually it takes about 10, 15 years to sign a treaty, go through cabinet and parliament for approval. When AMA landed in Sierra Leone, we took it to cabinet, took it to parliament. It got ratified in 10 days.
Wow.
So it tells you how serious this is to Sierra Leone. Again, with the knowledge that as a small country, but with the big global markets, it's virgin territory to invest. On the Abuja Declaration, I don't know why Sheila asked that question. She should be answering. She should be answering it for us. But honestly, it's a very strong aspirational goal. Again, I think one has to be very 15% of $1 million, 15% of $100 million are very, very different things. So I think we have to go beyond those percentages and see what you actually get. In Sierra Leone, between healthcare and education, we spend about 33% of the country's budget on just those two things. So we went up to about 11%, 11.6% in health. And at times I'm really worried, scared to ask for more, because who are you taking from? You know, it's a very challenging environment. And so with COVID, and we went through Ebola, and we went through all of this, all of the extractive mineral industry, they all departed. The revenue plummeted. So we're slowly rebuilding the resources, but we are committed. We're committed to Abuja, and will ensure that everything we do walk in that direction. Having said that, efficiencies are very, very paramount. Even what we have, how could we make sure we get value for money? We get the biggest bang for our buck. We invest it in the right places and reduce waste and abuse. On the issue of training, it's a very sad story. We've gone past the emotional side of it and the moral questions. It's gone way beyond that now. In Sierra Leone, over the past years, we've trained about 1,500, 2,000 doctors in Sierra Leone, all paid for 100% with government resources. Only 500 remain in the country. So again, I think there's a moral code of conduct that was passed by WHO and others, but nobody's adhering to it. Everybody's like, it's an open market, free world. You can do whatever you want to do, post your qualification. That's our dilemma. So what we're doing in Sierra Leone is to look at a 360 approach at health workforce. First, forecast the need, train towards that need, ensure that you deploy based on the need in the country, and work actively on retention. The active retention includes even basic things like internet access, like research capability, like being able to do implementation science or basic research, allowing you to do postgraduate studies in your country itself. It's going to make a world of difference. We used to enroll about 50 students a year in the medical school. Just before I came here, the number's gone up to 600 a year. So again, we're addressing the supply side, but until we look at the retention, until we look at the distribution, we're generating doctors for the rest of the world.
Thank you so much. Dr. Mort, I'm going to turn to you for the perspective from Kenya.
Thank you. Let me start with the Abuja Declaration. Again, echo the sentiments of the earlier speakers about the tight fiscal space that you operate in. Many African countries, you know, the debt stress compounded again by the climate crisis. For example, in Kenya, we had a Eurobond that we had to retire at a higher interest rate than ordinarily would have happened if we were not to default. So the numbers keep fluctuating. One financial year, the figures go up. Another financial year, they go down. But I think what we need to do going forward is probably how do we think of baking a bigger cake so that it can be able to cater for all our needs? How do we seal the loopholes of tax evasion? How do we address the issue of corruption and inefficiencies? How do you leverage technology to be able to do things better than we have done before so that we can be able to stretch the shilling to be able to offer us more services? Regarding the human resources for health, again, same story. But I think we should not just lament. I think it's a high time Africa we started to commoditize health workforce for the global community. How do we negotiate bilateral agreements with the West that are favorable to us, that as you allow these ones to go, in return, you are going to be able to invest this amount of money in training institutions. Further, in Kenya, we have gone ahead to start and really promote collegiate training. Instead of getting everybody to the capital to go and do residency program, you can be able to do your residency program in your county referral hospital with the support of specialists from all over the place. That way, it means that you continue to offer service as you train. And therefore, there will be no gap that will be left when you go probably to go to the capital for training. In terms of accountability, I think it's important that government, in terms of regulations, policies, rules, that we are predictable. But I think we also need to have a functional justice system that can be able to make the private sector confident that in case there's any dispute, then it will be litigated expeditiously to the satisfaction of all parties.
Thank you so much. Unfortunately, we've run. Unfortunately, we've run out of time, but I can tell from the room that there's so many more questions that people want to get to. So what I'm going to do is I'm going to ask my panelists to take seats up here in front. We're going to go into some reflections, but afterwards, I know there's so many people who want to engage with you. So please take your seats up here in front and I will continue this engagement.
Thanks to Rumbi Chakamba, our associate editor at Devex, and do follow along on Checkup. Sign up to our newsletter and get more insight and perspective on Devex.com. So before we bring today's event to a close, I'm delighted to welcome back to the stage Tayo Erogbogbo, Director of Multilateral Organizations Engagement at MSD and Advocacy Lead at MSD for Mothers, together with David Clark, Acting Unit Head, Health Systems, Governance and Policy at the World Health Organization. So welcome to you both. David, perhaps we could start by asking you to provide us with a few reflections. I know you wanted to talk us through the recent WHO scoping review on barriers and enablers of private sector engagement, and perhaps you could talk our audience through that progression pathway and the in-country response, and then I can move, Tayo, to you to share a few final thoughts and give our audience a call to action to leave here with today. So David, over to you.
With pleasure, thank you. So you might wonder why somebody from WHO is sitting on the stage talking about the private sector. Well, it's because we have to, because we've heard today just how important the private sector is in mixed health systems. So we've talked a lot about mixed health systems, but who in the room knows what a mixed health system is? Can I have a show of hands? Do you know what a mixed health system is? Do you know what we're talking about? A mixed health system is all of the health systems in the world. All of the health systems in the world have both public and private actors. And from our research, we found that around half of each country's health system is private. Yet, governments aren't necessarily stewarding them or using them efficiently to provide the best healthcare for its population. So in most countries in the world, governments are only working with half of the health system. So what we're trying to do with our work, and we run the Country Connector, is look at why this is and look at how we can support governments to change the situation. And one of the big issues that we work on is governance. And I heard three of the ministers speak about this, the importance of governance, the importance of creating the appropriate policy environment for working with the private sector. And we did a scoping review last year, which we'll distribute to people who are interested, to look at what the problems are in the system. And it's things like data. It's things like not having interoperability between the public and the private system. It's things like weak regulatory systems. It's things like not having the ability to enforce appropriate regulatory environment. So to fix this, what we're trying to do with our member states, and currently we're working with 3 African countries, 3 countries in the Eastern Mediterranean region, and 2 countries in Europe, I think 2 countries in Southeast Asia, is work on this thing called the progression pathway. So what we've recognized is that most that many countries, not most, many countries struggle when it comes to working with the private sector. They struggle when it comes to their regulatory systems, their policy systems. So what we're trying to do is help them to get them better. We're not telling them what to do, but we're giving them a process to help them to decide how they should set the policy and regulatory environment for their country. And the idea behind the title, it's about progression and a pathway. So it's not like saying, this is not like an assessment that you do once. This is paying attention to the need to strengthen the capacity of governments to work productively with the private sector. And again, we are laser focused on outcomes for better health outcomes. We're interested in better health, maternal and child health, and health overall. So I'll stop there, but we're very interested in discussing the approach with other countries. Any other country who's interested in discussing this with us, we're very happy to work with them. We also have another project that we're doing, and I listened with interest to what the ministers were saying about their work on data and digital health. We have another project where we're trying to better understand why we have such a problem when it comes to the private sector data. And that's a big problem because it's not just about interoperability, it's also about the government making better decisions about how to work with the private sector. So that's another area that we're really happy to discuss with any partners or governments that would like to discuss with us. But I'll stop there so Tayo can give his closing remarks.
Maybe a few closing remarks, Tayo, some reflections from the ministers and our esteemed guests who are still sat in the front row.
Sure, and thank you very much again to all our guests. For me personally, and I know on behalf of our team, this was really exceptional, and actually what we hoped this was going to be, which was basically hearing from those that are on the ground about what the capacity in terms of responding to the needs on the ground are, and the opportunity to engage with the private sector to fill those gaps and to work collaboratively in terms of improving health outcomes. Ultimately, as David has said and everyone else have said, that has to be our focus. And from what we've heard, there's massive opportunities for us to all contribute towards that goal. So when we're here again in next year and here in the next few years, we're not going over the same narrative around why should we be engaging with the private sector? What role can they play? We know what role we can play. We know what role private sector is already playing in these settings. The question is, how do we better govern, as David said, the health system to help respond to this? And then the last point around accountability, which you help raise, is that accountability is for everybody. And that's another element in which we work very closely with David's team on the Country Connect for Private Sector and Health. And one of the things that we reiterate is, accountability can't be just for private sector or public sector. And one of the things that the Lancet Commission Health Systems Strengthening told us is that we're actually failing, unfortunately, across sectors. So unless we really invest in that capacity to understand, as Dr. Honorable Minister Dembi said, to understand what is happening both public and private, we're not going to move the needle. And we need to also put ourselves in the shoes of the mothers that we're working for. They don't understand public, private, as one of our speakers said. They walk between these different facilities and different capacity. But what they expect, though, in uniform across all our health system is quality, because ultimately that's what saves lives. So, I mean, just as a closing point, from an MSD for Mothers perspective, we would love to really hear from partners that are working in this space to help, not just in terms of programmatic work, but actually in terms of thinking around how we respond more effectively to the gaps, particularly in terms of how we work better together in addressing some of these issues, particularly actually around the narrative. It may sound a very nuanced thing, but the narrative around how we work together is really important and why that is important. So thank you very much. I'll pass it back to Richard.
So language matters and laser focus was my other key takeaway from today's session. Many thanks for everyone for their insights. Big thanks to you, our audience, everyone watching along online at home. A big thank you again to MSD for Mothers and the WHO Country Connector on Private Sector in Health for helping us to power our journalism on this stage during WHA. Stay tuned for more on Maternity Matters. This is our content series running on Devex.com. And stand by for an action-packed day 2 of Devex at WHA 77 tomorrow from 9 a.m. CEST. So from all the team here in Geneva, have a productive rest of your evening. Thank you very much.
Can we just take a quick picture?
Sorry,
a quick picture.